Greetings. Let us learn about OTSC, over the scope clip. So the over the scope clip comes mounted on a cap, and you load that cap loaded over the scope clip onto the end of the endoscope. There are several varieties of clips, and you could recognize them by the shape of their teeth. Here, the first variety has relatively blunt teeth. Next one has short spikes, and the last one has longer spikes. So let us learn about each one of them and their function. So this is OTSC type A clip, has blunt rounded teeth and useful for hemostasis. Next one is type T clip and with small spikes, good for closing perforations. And the last variety is a GC clip, and the GC clip is identified by longer spikes, and this is only used in the stomach, preferentially for peg site wound closure. So let us learn a little more details about these different types of clips. It's very important to know. So here is the OTSC clip, and it is identified by several parameters: the size of the cap that fits onto the endoscope, the maximum outer diameter of the cap, the depth of the cap, and the type of spikes. So as you can see here, depending upon the size of the cap that fits on different types of scopes, they're known as mini, 11 millimeter, 12 millimeter, and 14 millimeter. And it's important to know that the 11 millimeter cap has a maximum dimension of 16.5 millimeters. The 12 millimeter has a maximum outer diameter of 17.5. And the 14 millimeter cap that fits in with therapeutic scopes has a maximum diameter of 21 millimeters. And why is it important to know this? Because if you have somebody with a smaller esophagus, picking up a bigger cap doesn't work. If somebody has pretty bad cervical spondylosis, which makes it very hard to introduce the endoscope with a cap that has a big diameter of 21 millimeters. So we've learned about the size of the cap that fits into a particular scope and the maximum outer diameter. And all the caps, OTSC clips, have two depths, a 3 millimeter depth or a 6 millimeter depth. Except the mini has 6 millimeter depth throughout. So when you open a packet and you see that it says OTSC 11 by 3-T, what does it mean? It means the cap size is 11 millimeter, that is 11 millimeters, and that will help you to figure out on which scope does this cap fit in. And the maximum outer diameter of the scope that this can fit in is 11 millimeters. And what does 3 mean? 3 means the depth of the cap, that is 3 millimeters. And what does T mean? It is describing the type of teeth. Here T is small spikes, that is T. If there are no spikes but is blunted, it will be A. If there are long spikes, it will be GC. All right. So we know that 11, 3, T. What is it? But not only it's 11, 3, T, you should know that although it is 11, 3, T, you shouldn't assume that it is just 11 millimeters. It is actually outer diameter of the cap is 16.5 millimeters. So that number to me is very important to figure out whether this will go down somebody's throat and esophagus easily or not. So I would want you to look at the different sizes of OTSCs so that mentally you can figure out. So the first number tells about the cap size that fits on a particular scope. The second number tells about the depth of the cap. The third letter talks about the type of spikes, blunt, short spikes, or long spikes. And the number that is not missing there, 16.5 here, is one you should keep it in mind that add about 5 to 6 millimeters for every cap size to appreciate that the actual outer diameter of the cap is much bigger than what it is on the number. So OTSC, basically the principle is very simple. You basically go to the area of interest, apply either suction or traction, and bring the tissue into the cap and release the clip. And we will learn a little more about how to set up the OTSC for a procedure. So when it comes to OTSC setup, you need to learn the different parts of the system. This is a cap and a clip, that is a cap loaded with the clip already, and that is attached to a thread. And there is a thread retriever, and finally a hand wheel. So these are the three components. It is pretty easy to set it up. You take the OTSC wheel, place the hand wheel over the biopsy port, and take the cap off and put it on the biopsy port. Then insert the thread retriever into the hand wheel and push the thread retriever till it comes out of the biopsy channel. It is similar in principle like the band ligator that you have seen before. Then attach the thread to the thread retriever and pull the thread through the biopsy channel. And once the thread comes out, you wrap the thread around the hand wheel, and that will secure the device. So once you have the OTSC cap comes closer to the distal end of the cap, you load it on firmly to the maximum depth that it goes to the distal scope end. And then it's important, like the band ligator, you want to rotate the OTSC cap so as to align the thread to the biopsy channel so that you have a better view. So this is the setup of the OTSC, and the principle is, say for example, it's quite often used in the management of peptic ulcer bleeding, and the principles are simple. You go to the site of the bleeding, you apply suction or traction. We will learn about traction, suction or traction, and then deploy the clip, and the clip gets deployed and secures the bleeding. So let us learn about the different ways that the OTSC could be deployed. And I talked about two principles. One is suction followed by clip application, and the second one is traction followed by clip application. So let us look at suction technique. So here is a bleeding, and the bleeding is coming from an area without much scarring. And in this case, you could actually apply the suction technique, which is fairly simple. You go on to the site of bleeding, unfause, and apply the suction. And once the tissue is in the cap, obliterating the view, you deploy the clip. One important thing is you need to know your anatomy, and you need to visualize what are the surrounding structures when you're applying the suction technique and deploying the OTSC clip. People have had problems with this. What I mean is, when the suction, if there is a surrounding loop of intestine, it can get trapped in. If there is a surrounding, in the surrounding area, if there is a ureter going by, it can trap the ureter. So if you're very close to an opening, like a pylorus opening, you could accidentally close the pylorus opening. And in small bowel, people have described closing the small bowel completely. If you suck the whole wall, and the circumferential wall comes around a bend, you can actually occlude and block it. Fortunately, there are devices now to break this clip using electrosurgery principles, and that is something to keep in mind. So when you're trying to suction, you have to be careful about these adverse events. Next, let us talk about the use of a tissue grasper. The system has several different pieces of equipment, and the tissue grasper is useful when there is bleeding that is associated with scarring, like a chronic ulcer. And in that case, you can use a tissue grasper, grasp the tissue, bring it back by traction into the cap, and then deploy the clip. All right. Next is, there is what is called a twin grasper. So it has two blades, and with a central a separator, and this is useful for closing perforations that are large, big defects. And how do you go about it? It is very important for the assistant to know whether he is opening the left blade or right blade, and that he has to figure out mentally, and do a practice before giving this a twin grasper to the endoscopist. So what the endoscopist does, he passes the twin grasper to the middle of the defect, and he will ask you to open the right blade, and then close the right blade, and then go to the left side, open the left blade, close the left blade, and then grasping both the edges, pull the twin grasper back into the cap, and it is important that the whole twin grasper should be inside the cap. Whenever you are doing any traction type of technique, the instrument that is used for traction should be completely inside the cap, nothing outside. If it is outside and the clip is deployed, the twin grasper can get stuck in the clip and it will be difficult to get out of that problem. So make sure that it is inside, and it's a good idea to do a timeout and make sure and say, hey, is the twin grasper inside? If everybody agrees, then deploy so that it comes out safer. Next is closing a smaller defect, like chronic defect, like a fistula, in which case you could use what is called a tissue grasper. This is specifically for smaller defects. And here is a tissue grasper. It has two arms, and you put it into the center, open it, and the curved hooks will hook onto the tissue and then bring it back. Again, always the tissue grasper, like the twin grasper, should be inside the cap before the clip is deployed, so as to getting into trouble by having the clip grasp the tissue grasper. So we talked about bleeding without scarring, bleeding with scarring, small defect, large perforation, defect with scarring. Different ways that we could manage these problems using these different techniques. Coming to the adverse events, we talked about them already. One of the things you need to keep in mind is the entrapment of adjacent structures, like a loop of ball or ureter, especially if you're doing the procedure down. And ureter, if you're doing it in the duodenum as well, it can happen. And also inadvertent closure of lumen. Cases of pyloric closure, duodenal closure have been reported. I hope this is useful. Thank you.